for putting up such an educative material for last few months. This is my finance and disclosure, and it's not moving here.
Bottom. Yes, sir.
I'm going to speak on a clinical performance of PanOptix in using situation. Are you able to hear okay?
Yes, sir. Perfectly all right.
I think we are unique in many ways, and therefore it's very important that we make this new technology for our dear patients very relevant. We understand the various options over the years which has developed. One, IOL-based, different multifocals and different trifocals and different kinds of IOLs versus simple monovision strategies. The monovision strategies have been in use by a limited number of people, and they enjoy that. But because the refractive target is not symmetrical and identical, majority have an issue with them. So these ASCRS survey in 18 showed 65% of the ophthalmologists would implant a IOL-based approach if the patient has never taken a monovision trial or not happy with that earlier. Of the ophthalmologists, so that's fine. However, the fact is that only 9 or 10% actually receive these IOLs. And the reason these members of the society gave was they were a bit concerned about the quality of vision with what the available multifocal lenses were there at that time in terms of its efficiency at different distance and negative dysphotopsias and contrast sensitivity and so on. And also, they found it was rather expensive to the patient. So these were the two main reasons that only 10% of the patients had that IOLs. And these popular multifocal options at that time and even now are the +3 or ads of different companies. And they enjoyed that for many years, the benefits of distance and reading vision. And then because the intermediate vision became a priority in the lifestyle of our evolving world and many activities that depend on the intermediate vision, attempts were made to give a kind of low-ad multifocal, as it were, like 2.5 Restore or Oculentis or Symphony, which all of these act like a little bit of an intermediate vision capability in addition to the good distance vision. But they never had a good reading vision, and they had a contrast issue with the low light. And then the trifocal IOLs introduced by Physiol and Zeiss at Lisa came, and then later on the PanOptix came. But the traditional multifocal had, as I said, far and near vision at 30, 40 centimeter, and they never had a great intermediate vision, but also had a lot of halos and glare bothering many patients. The low ads, which came up later on, had a better intermediate vision, but not that great. And still, they wanted extra light and contrast sensitivity and always, more or less always, reading aid or intermediate problem. One could solve to an extent the blending multifocals like the monovision with Symphony or monovision with monofocal, but all of these has their own problems and they never became very popular. But it did give some range from near to far. So that was a strategy until the trifocals came, and more now, trifocal implantation has been practiced, I believe, and that's because the intermediate focal point, which used to be 70, 80 centimeter, worked quite well. And then it produces a good high resolution images at different distances and practically in many light conditions. And also could switch back with less dependence on the additional appendages of glasses. So typically trifocal from infinity or distance was fixed to 40 centimeter, and then the second order was added like a base of the pizza, and they were attached there. And then with the phasing of the optical principle, it has to be 80 centimeters intermediate distance. And this slide explains what it means. With the distance correction on the 40 centimeter, if that is a desired, and it is a good near distance, one has to have half diopter, half of that, and wider distance between the rings, giving an intermediate. And because, as I said, the wavefront and the phasing of the optical lights, it has to be on 80 centimeters. So the intermediate distance became 80 centimeters, and it worked quite well until we really went again and found out and researched. And there are two big institutes and papers which emphasize that the intermediate distance, 80 centimeters, is okay, but if you have a 60 centimeter, which would be kind of an arm's length with the majority of the people, would even be better and more convenient. And with that information in the background, Alcon brought out the PanOptix IOL, and that helped many people. And then people who wanted to prove their points, they found it very useful with that 60 centimeter distance. And it worked in all kinds of people, the professional people, the people who enjoy the life and they work hard in the kitchen. It worked quite well. And what the PanOptix IOL does is, unlike being a full diffractive in the entire optic zone, they have selected a 4.5 millimeter zone of diffractive zone. And mind you, unlike the previous apodized lens, which actually, as we go from center to periphery, the light energy distribution changes and becomes more for distance, it was not like that. And it was like a conventional diffractive zone, but the diffractive rings, but only in the central 4.5. And the 15 rings, after a lot of research, was the optimum size of the ring. And the outer rim becomes, therefore, a refractive, mainly used for the distance vision. And this slide illustrates, if you have a less than 4 millimeter and restore a head less than 4.4 millimeter diffractive zone, it would actually compromise near and intermediate performance when the light condition goes down. And therefore, in the restaurants and dim light, they had the problem. If you have a larger, and the other trifocals, which are very good trifocal lenses, have however, a larger 5 millimeter, more than 5, also has a compromise on the distance vision in the light condition. And in the mesopic condition, typically most of us use distance vision and not a reading vision. So that really is an issue with a full diffractive. And therefore, 4.5 appears to be fairly good optimum size, and is also less dependent on the pupil size with different conditions. And the trick they did was that they had a third order of 120 centimeter distance, and then they chopped half of it and produced that 120 to 60 centimeter. There's a little trick they did on the pasting on the base of 120 centimeter, like, as I said, remember the pizza platform, but you have a certain laws here. You cannot add on with any distance. It has to be particular distance and in the face. So that they produced a 60 centimeter distance. And similar thing I can illustrate in a different way, that the multifocal original was straight one order, distance near, and then the trifocal added here a second order, which gave a 80 centimeter intermediate distance. And then they added originally 120, but then they chopped off that, and they called optically it is actually quadrifocal, although it's trifocal. In optical language, it's quadrifocal, because originally it was that which was being used to the benefit to bring it to 60 centimeter. And what it gives is this, that if you see here, the defocus curve from minus, it actually, this 80 centimeter to 40 centimeter is more or less a good quality more than 20/25, 6/9 vision, which is in a kind of a continuous range. It doesn't dip. When we compare it with these two other trifocals in that region, 42 centimeter, some of them would, both of them would actually have a gap here, which will go down in terms of his visual performance, unlike this, which remains more or less in the same flattish curve. So that's the advantage in optical language and defocus curves produce. In real terms, in the patients and for us, what it means is the near remains 40 centimeters like other trifocals, but the intermediate comes from 80 centimeter to 60 centimeter. And then the other part of the way the light, this energy is distributed, and that is distributed by moderating the height of those diffractive element. And they're done in such a way that 88% of the light is reaching retina, the rest is diffracted and lost somewhere. So 88% transmission to the retina is higher than which is achieved with the other trifocal. The difference is not great, but it is sufficient enough to make a difference in real life scenario. However, it also has the same trade-off like the other trifocals and other diffractive element-based lenses. They do have halos, and in the mesopic conditions, they do have a lower contrast sensitivity. But the good news is that whatever the reason, I don't think we understand, the halos is less than what we would expect from these diffractive elements ring. And the mesopic sensitivity, and we'll come to that a little later, is quite good in real scenario. So with that, if we want to summarize this PanOptix, which is a newer entry into these trifocal IOLs, which appears to be gaining popularity amongst the surgeons and patients, strategy is that it is quite comparable to monofocal IOL in terms of its performance in the photopic conditions. And the best part, this is the part I really like very much, and I find and discover from the patient that there is no problem from a very close, and some of them are needed 30 centimeter, 33 centimeter, 40 centimeter, up to 80 centimeter with a smooth, continuous, same quality vision, and great spectacle independence, and we'll come to that a little later. The actual, from a surgeon's point of view on the table, it behaves like a single piece hydrophobic IOL, like Jan, like many others, and Ecrisoft has its own unique characteristic of slow unfolding and can go with the 2 or 2.2 millimeter incision with the preloaded, without preloaded, and there's no difference. So unless you know it's PanOptix, you won't find any difference if you're used to this platform length. But that's one thing. And another thing I want you to notice is this big little area in the central, the bullseye. It is quite larger than the previous IOL designs. So having understood that, I now want to spend more time, and I want you to attend some parts very carefully of this Alcon initiated multicentric study, which was done at Professor Dr. Ramamurthy's place, L.V. Prasad Institute, Shankar Netralai, and Narayan Netralai. We completed the study, and it's been a submission stage. And Dr. Ramamurthy, I'm glad to say, the lead author of that manuscript, which is in the submission stage at the moment. And the study design was a single-arm, multicentric, unmasked prospective study to evaluate its performance. And the inclusion criteria, however, was not that good now, but at that time was the patient has to have an astigmatism less than a diopter, which is not, it's not very common. So we had to wait to get the right patients. Now that the PanOptix toric is there, it's not an issue, but this study was PanOptix in patients less than a diopter astigmatism. And in addition to more astigmatism, comorbidity patients were excluded. And the primary outcome measure was the best corrected bilateral distance corrected vision. And mind you, now it's not 6 meters, it's 4 meters. And that's what is the now accepted recommendation by the leading institutes and authorities. So secondary outcomes, and it is a secondary outcome that I am interested in, I was interested, and that is that what is the uncorrected distance visual acuity, uncorrected intermediate visual acuity, and uncorrected near visual acuity binocularly, and understand this based on the binocular defocus curve. And we had to report some other corrected vision at all the distance and make sure that subjectively they are accepted okay. And we had to look for a hazardous unwanted adverse effects and a posterior capsular opacification and so on, like any other studies based on such intervention. And we standardized our technique of measuring it, and we then followed it up, as you can see, with a kind of a measuring devices. Totally 68 bilateral implants were studied of the 80 patients that we had. And this is the binocular distance corrected vision versus uncorrected 660 and 69, 20, 25 better. And mind you, overall, uncorrected was, the list was 78.8%, and all had more than 78% patients achieved binocular 6.9 vision or better. In fact, majority were better than 6.9, and some of were 6.5. And on subjective assessment, and I'll report that a little later, 94% reported minimal or very little use of the glasses. This is the binocular best corrected distance visions with, versus uncorrected vision. And as I mentioned it earlier, best corrected 92.5% achieved a 0.1 logMAR unit, which is little more than 6.9 or better at 3 months postoperatively, and 83% uncorrected. Same thing, binocular uncorrected intermediate vision, and this is the slide that I am really interested. 81.8%, 82% achieved binocular uncorrected intermediate vision of 20/25 or better at 3 months post-implantation. And that has made this lens very acceptable to the patient and the surgeons who started putting it below this aspect of this PanOptix. The near vision, like the multifocal, traditional, and others, is quite good. 78.8% achieved uncorrected near vision binocular at 3 months. The near vision was a question mark in some of the earlier modification of the traditional multifocal, like Symphony, 2.5 Restore, and so on. This is quite acceptable. In some situations, however, very traditional multifocal would have an advantage of a slightly better reading vision, but as you know, on the balance, on the checklist, this is very good, near vision uncorrected as well. So if we say the question is, how about the vision at distance, intermediate, and near? That's what we are in life. We don't check separately. The report was on a separate near, intermediate, distance. In reality, what is that? The composite vision, as the new terminology is, that at all distances, the vision of 0.1 logMAR or better was in 65% uncorrected and 71% corrected. We would expect these remaining patients to wear glasses, but whatever the reason, only minority needed glasses, and we'll come to that very soon, in spite of that figure. Now, we saw the defocus curve, and this is a similar thing represented in a little different way. These may look a little intimidating, but this is the 6.5, 6.6 vision, and 0.1 logmar unit, that means 20, 25 or better depth from 0.5 to 2.5. So it is quite a good kind of thing with a good vision here and a very, very flat curve here, which suggests a good vision from 40 to 80 centimeter and beyond. This is, as I said earlier, is the reason of a patient's very comfortable. And as I said, in spite of 71% binocularly corrected had a composite vision of 9 plus, 98% reported very satisfied with their vision, and they really had terrific freedom from glasses. 94% or higher had a spectacle independence in a composite or in each distance. So this is very, very good and very reassuring. This is that contrast sensitivity I alluded to. Being diffractive element, there is a limit to what we can do. The contrast sensitivity at a higher CPD, in other words, higher spatial frequency would be reduced to some extent. So the high resolution could be compromised in a testing conditions, but what is more important is that up to a limit of CPD, the spatial frequency, which is really requiring, which is needed or necessary when you walk in the mesopic lights or when you work in a mesopic condition, there is hardly any drop in the contrast sensitivity. So I think this is something which is better than what we were dreading, and this is really very nice. So in that multicentric study that all these centers did, the conclusion was that there was possible to get a continuous range of vision of 0.1 logmar or 20/25 or better in this defocus range, which means 78% and more had the binocular 20/25 vision or better across all distances. And there was a remarkable reduced need for spectacles. And there was a sufficiently good mesopic contrast sensitivity, which as expected was little less with glare, but that was quite good. So that was the conclusion that Multicentric did. Now, if you want to adapt for those who are not tried the trifocal in general, whatever the companies you want to do that, no problem. You must see that you customize, made for you approach. But the basic is that get your preoperative data right. You may have a separate preoperative workup. You may have a separate team and technician devoted only to do preoperative and the counseling for that. But whatever you do, get your data right. And one example to illustrate that, first, perform the keratometry before you touch the eye. For example, if you have done applanation tonometry and then you do it, it will be different. So lubricate this eye, make sure tear film is good, and you will find a significant difference in your keratometry and IOL power. So be careful, pay attention to the details, use the appropriate formula. You can have a Heal RBH formula. We like Barrett Universal 2, and we use other modifications of Barrett as well in some other situations. Angle alpha is a concern in all diffractive and multifocality situations, but the good news is, I believe, this is not a scientific statement, but I believe with a larger central zone or a bullseye, as I would call it, PanOptix may be more forgiving for a little larger angle alpha than we would select, or we used to select for multifocal, but the time will tell. I think we know now how useful it is to spend time. Very briefly, two examples. One is a maxillofacial surgeon, had a posterior polar cataract, a very youngish man in his 40s, and had a typical posterior polar history of allergy and glare and so on. And his problems was really, he was a microscope surgeon as well as a dental chairperson, and he never liked wearing glasses. So we discussed, and whatever At the end, we decided to give a good distance vision, but a bit of intermediate as well, and accept him to reader, which he accepted. And at that time, PanOptix was not available. Trifocal was just introduced 2 months ago by Physiol. So we decided to use 2.5, and he was very good in terms of his recording. And he was very happy at that time. And he didn't come for more than a year. And then the PanOptix was available when he came. And when we asked him, he said, yes, I'm managing, but I do have a strain when I perform a near work for a decent time. And can we relieve that, and can you improve our reading vision, near vision now? And we said, yes. And then we did a PanOptix in the right eye. We warned him that please do not close one eye like most of my patients would do it when the second eye. They always complained that I paid more for the second eye. It was painful on the table, and I don't see as good as my first eye was done by my competitor across the road who charged half your fees. So I said, don't compare two eyes, and use the both eyes, and you will be very happy. And as expected, he was extremely happy with 2.5 in one eye. So in other words, a blending, as I alluded to in earlier time, monovision blending, symphony blending, different multifocal blending, you can consider, although I would not recommend it as a routine, but this particular example, it worked very well. And he is very happy. By the way, he was a national table tennis champion. Some of you would know him. He went 3 weeks later to take a part in Spain. I don't know how he performed well, I won't tell you, but he did quite well, actually. This is the last patient. A lady is managing one of the biggest crockery companies in India, and a very social active lifestyle, as you would imagine. And these people spoil their health, and they're diabetic and had always been astigmatic. So we performed bilateral PanOptix torics, and vision was extremely good binocularly and at 60 centimeter and 6. But I just want her to listen to you for a minute.
Need to wear glasses. You feel the need to wear glasses now for any fine work?
Not at all.
Not at all.
Not at all.
That's
I can write very well. I can read very well. I have no problems.
Would you recommend the surgery with the multifocal toric lens to others?
Of course, why not? I've already suggested my friends.
So finally, to conclude, I think PanOptix IOL implantation gives a very good intermediate vision at 60 centimeter. And there is a continuous smooth vision from near to intermediate and beyond. Very high subjective satisfaction, and it enjoys the basic platform of this lens, and it is hydrophobic, single piece, Acrisoft, and all the goodies or negative, whatever that is. It has the advantage of that in that platform. So thank you so much for your patient hearing. I think we will continue with the other topic and then come to the discussion.
Yes, sir. I think